Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi again, welcome back to the Bridge to Health. My name is Dr. Tom Dow, and each week on my show we have a special guest who is in one of the healthcare disciplines, some weeks conservative, traditional healthcare, other weeks alternative healthcare. But our goal is that these healthcare members all work together as a team for you, the patient, to give you the best care possible with kind of like an a la carte menu of things we can choose to give you the best chance of crossing that bridge and getting to the other side and attaining maximal health. This week, I want to welcome back Dr. Sal Corso. Hi, Dr. Corso. Welcome back.
How are you, Dr. Dow?
Excellent. And the last show we had was an awesome show. It was on medical marijuana and its uses for patients in chronic pain. But today, I want the audience to get to know what an orthopedic surgeon does, what kind of patients the surgeon sees. And really, what I want the audience to know is I want them to learn a little bit about Sal Corso.
Sure.
Is that okay?
That's absolutely okay.
So, Dr. Corso, when did you first have an epiphany that you wanted to become a doctor?
Well, it's funny because growing up in Brooklyn, my background, I was in a tight-knit family, Italian family, and I wanted to be a vet originally.
Less complaints from patients that way.
A lot less complaints, but then I couldn't talk to them as much. I
Right.
guess you could talk to them, but I don't know what kind of responses you get back.
No arguments.
No arguments. But I really wanted to be a physician from a very early age, and I really put my mind to it. I had a tremendous family support to go ahead with my dream, and I think I was pretty much a professional student through school. I did go to Catholic school. I think it helped me as far as discipline. Not that now my children have gone to public school as well, so it's I don't think that's as important. But for me, it was a good thing. And back then we had the nuns, and they would whack you if they had to.
Oh yeah.
But it was all good. And as I said, I really wanted to do it from a young age, and I really focused myself into that and to attain the right grades. It was always difficult to get into medical school, but I was able to get into Brooklyn and downstate. I went to SUNY Downstate, and from there, everything took off.
So medical school, 4 years, then you had to do your residency. How many years is that?
5 years of residency in orthopedics. When I was doing my rotation when I was in downstate, they give you a clinical rotation that you can electively choose different things that you may want to go into. And I initially wanted to do heart surgery.
Interesting.
But I noticed that there's a lot of stress involved. Then I did a rotation through the orthopedic service. I was always, big into sports. I played a lot of sports as a youngster.
What sports?
I played baseball and basketball. Didn't get a lot of injuries when I was young. The pain and stuff came later on.
I know the feeling. Yeah.
But I always remember doing the rotation in medical school, and it seemed like the orthopedic guys were having a good time. And I think I was able to, I certainly made the decision that I'd like to have a good time, maybe not be as stressed out,
Sure.
and still take care of people, be able to develop relationships with patients, and also to, orthopedics, you get an immediate gratification a lot of times. You're
Right.
able to, if somebody tears an ACL, you can fix it. If somebody tears their rotator cuff, you can fix it and make them better. So that really attracted me, and that's what got me into where I am now.
Must be very rewarding when you got somebody that can't move their arm, and 6 months later they're back playing sports again.
It's a very satisfying experience, and especially nowadays, as you know, with the changing in medicine, people that think that you go into medicine to make a lot of money, and certainly I'm not complaining because we certainly do well. We have a nice occupation, and it's well respected. But with the changes that have occurred, I think if you're into medicine for anything, at least for the satisfaction of caring for your patients and,
Right.
and making them better, then you're not in the right field.
Right. Tell me a little bit about Dr. Corso. What hobbies do you have? You have kids. I mean, what's your regular family life on a regular basis?
I'm sure I speak for a lot of other parents that my hobby is my children.
Yeah, me too.
And I say that with a little emotion, but my kids are everything to me, and as well as my wife and certainly my family, my occupation. But I have 4 children. I have 2 from my first marriage. I have 2 older boys.
How old are they?
Twins. They're 23. One of them works for the Vikings. He lives in Minnesota. He does digital media as well as journalism.
Wow.
So the sports thing went right into him. Did not want anything to do with medicine, although he's certainly disciplined that way and has been very successful. And my other son is working in the city for a record company. He's a business major that wants to get into a little bit of music.
Nice.
So he's doing that, and they spend a tremendous amount of time with me. I'm flying out to Minnesota in a month to see my son and grabbing the other guy and taking him with me.
Nice.
And I also have 2 younger children through my second marriage that are spectacular. One is 7, going on 8, going on 28, knows everything, plays also a ton of sports. I just dropped him off at golf camp this morning, which is a little bit of a hobby, and I'm going to have to start getting back into that because he's getting very good at it at a young age. And I have a younger daughter, of course. My last one, my princess, is 5 years old, just graduated kindergarten.
Nice.
Just a spectacular kid, a beautiful girl, and she's given me that father-daughter relationship.
Beautiful. So when Dr. Corso wakes up on Monday morning and he now starts the week, tell me what a traditional week would be like. Your days you're in the office, your days you're doing surgery, how many hours. What is it like to be an orthopedic surgeon in your shoes?
Well, I'm going to go back a little bit for you.
Okay.
And after I finished LIJ, I did a fellowship with just a spectacular group of docs down in Virginia, Richmond. One of them was a doctor named Richard Kaspari, who was probably one of the pioneers of arthroscopy, certainly of the shoulder and even in the knee. He was probably a legend in orthopedics. So I was able to do a fellowship that gave me a tremendous amount of confidence coming out to do what I wanted to do, which was the sports medicine end of orthopedics. I certainly came out with a very good background from LIJ, North Shore, very busy emergency rooms and doing a lot of trauma and that kind of stuff. But my true love was to do sports, to operate on shoulders, to take care of patients with knee problems, shoulder problems, ankles, elbows, and so forth. So that fellowship really gave me a lot of confidence. My practice really is certainly a general practice. We really take pretty much almost every insurance that there is out there.
And what's the name of your practice again?
It's Orthopedic and Sports Associates of Long Island. We're located in Woodbury. Right. And I've been there since I finished my fellowship. As a matter of fact, I pretty much helped to start the practice, although Dr. Lepard, my senior partner, was there with another practice and split off. So we started that practice. We've been there for over 20, probably 22, 23 years now. And the practice is really a entire encompassing orthopedic practice in the sense that we have 5 docs. We each have a specialty. There are 2 hand surgeons. There's a gentleman that does joint replacements, and myself and Dr. Gutman, who do basically sports medicine.
Right.
The 2 hand surgeons, Dr. Cooper Smith and Dr. Lepard, and Dr. Mallon. I should mention everybody. But we have a great relationship. We have a great group of guys that work very hard every day. You know, when I come in, I do have a busy practice. I've been there for over 20 years, so I think I have a pretty strong following, and word of mouth is always a good thing. I think if you care for patients and you do a good job, they'll come back and they'll send their friends and family.
Definitely.
Monday morning is usually the busy morning because obviously you have your weekend warriors, you have
Right.
people that come in with a whole host of problems, people that have gone to the emergency room for issues. But I'll come in on a Monday and, I walk through the door. I know it's going to be a long day and it's going to be a lot of people, but I try to take the approach that I want to have fun. I want to have fun with what I'm doing. Not that I don't work hard, because it's hard work, and getting there was certainly hard work. But I always try to have a smile on my face. I want, if I want my patients to leave with a smile on their face and be happy and feel good, then I want them to know that I feel good.
Of course.
And I think that's important. I want my coworkers and my employees to know that I'm happy and that I'm ready to take care of my patients.
How many days a week do you see patients?
I see patients on a regular basis. Usually Monday, Wednesday, and Thursday are pretty much every week. Tuesday and Friday are operative days, but every other Friday I'm usually in the office also. So I'll be in the office usually up to about 4 days a week.
Gotcha. And when you're operating, is it like a full day from like 8 in the morning till 6 in the afternoon, or is it a half a day? I guess it can vary on your booking, right?
It can vary. The type of surgery that I really do mostly now is ambulatory. So a lot of my patients go home, which I think is a good thing.
Sure.
There was times when, certainly if somebody's in the hospital with a broken arm or a broken leg and needs surgery there, that would be somebody that would stay for a period of time. I've gotten away from doing a lot of those. We have younger guys that do trauma, and they do it very well. I had my day with that. When I do surgery, if it's at the hospital, the problem is, and I'm sure most people would understand, that a surgery center does run a little bit more efficiently with time. Time is of the essence. So my cases, I will a lot of times do a full day of cases. Certainly if it was at the hospital, I'd be there from 8 to about 5 or 6. But a lot of times in the surgery center, they may have an extra room so we can decrease turnover time, and I'll still do 4 or 5 shoulders, maybe an ACL and a couple of knee scopes.
Right.
So we may do 7 or 8 cases and still be done, in the mid-afternoon, but we start at about 7 or 7:30 in the morning.
Nice. And of course there are complications that happen sometimes, and things go longer than others, which may drag the day out a little bit longer.
There's a lot of things that, there's certainly things that can happen. Or there are a lot of things, I think everything is so systematically done. People say, oh my God, imagine operating on somebody. But just like they might, work on a car or something, and not that I'm not trying to compare a car to a person, but that's my job. I have to take some of the emotion out of it at times.
Sure.
And work business-like.
Right.
So everyone has a job that they have to do. They do it well.
Right.
We have everything that we need to pretty much fix any problem that I can come across in the OR.
Right.
So, and yes, there are times when I might be using one set of instruments, and all of a sudden I run into a little problem, and I say, hey guys, we need another.
Yeah. What I want to make clear to the audience is when you say run into a problem, diagnostic tests sometimes don't tell us the whole story. You really don't know until you actually go in there. And you may find things which weren't there on an MRI, it may prolong what you're doing and necessitate you to do more things that you didn't anticipate.
No doubt. There are what's called false positives and false negatives.
Right.
So you might get an MRI that shows a small minimal tear.
Right.
People have to understand, radiologists and even doctors are not looking at an actual shoulder on the MRI. There's signals that come out. You're looking at, parts, and it looks very, very close. But signals are what you see, not so much the tissue itself. So you might see some on an MRI, and then you go in, and it's a completely different picture.
Exactly.
So that does happen. But the great thing about it is you stay calm, because that's what experience brings you, that you've been through that before.
Right.
And you're able to tell people what you need, and you just move along and get done with it.
And another thing I want to share with the audience with you is that some people I've heard as patients, they say to me, well, I'm having surgery, but I really want to have it done in the hospital, not in an ambulatory surgical center, because they have the thought in their mind that a hospital is better equipped, or there are more specialists there in case there are problems. What they don't understand is that the infection rate from a surgery is much, much higher in a hospital than it is in a surgery center, because people come to surgery centers and they're not sick with bacteria or viruses usually. In hospitals, you have that, and that's another risk there that you don't have as much of in a surgery center. Would you agree?
Oh, there's no doubt. I think one of the misconceptions is people are always concerned about anesthesia.
Right.
I've been doing orthopedics for 23 years on top of the 6 or 7 years of residency and fellowship. And I can tell you that I've never had a death occur, thank God.
From anesthesia.
From any anesthesia, knock on wood. I've never really seen any really complication. There are patients that I will agree with you that have significant medical issues that might be better off, or you may be better off as a surgeon deciding to bring to a hospital in case.
Right.
But understand also, number one, that there are very minimal issues that ever happen again, and number two, there are protocols in place.
Right.
If a patient does run into an issue at an ambulatory center, where they will be transferred directly and immediately to a hospital.
Right.
So that is available.
Right.
But the majority of the average patient that I operate on, that I take care of with a rotator cuff tear, a sports injury, a knee problem, so forth and so on, there is no doubt that the surgery center is
Same
well
with me.
equipped.
I've been doing manipulation under anesthesia. We work together in the same surgery center, Melville Surgery Center, for 10 years, and I've never had a patient have any complication from any anesthesia that's been given. Again, like you said, not that it can't happen, but I've never seen it. And
No.
a lot of people don't realize how well-trained these anesthesiologists are. I mean, I've seen these guys without even a drop of sweat coming off the top of their head, bring somebody back who's desatted a little bit like that, and you and I might be,
Yeah, right.
But those guys, I mean, this is what they do.
And they work as a team.
Right.
So there usually is one anesthesiologist, not just kind of coordinating.
Right.
That's available right away if a guy needs some help.
Right.
But it's a very, very, very rare occurrence, and I've seen it really. If anything has ever happened, it's usually somebody who's sick,
Right.
who's in the hospital,
Right.
Who really may be, very, very.
Right. And what the public also needs to understand, that before you or I even bring somebody into the OR, they're getting medically cleared by their own primary care doctor to make sure they're okay for surgery, and they're being examined the day of by the anesthesiologist with vitals, with EKGs, to make sure everything's fine that day.
Right.
So there's double checks and safeguards to ensure they wake up.
No doubt.
and they're fine.
Yeah.
So tell me about what is the number one sports injury that your practice treats?
Well, I'm going to tell you, I would say, as it is probably universally across the country, the knee is probably the most common injury, but I'll put a little asterisk to that, certainly in my practice, and I'll go into that in a second. But one of the more common things is to tear a meniscus,
Right.
to sprain a knee, to twist a knee. It can be you and I stepping off a curb. It can be obviously a football player who gets tackled and plants his foot and gets dragged down and his body twists on top of his knee. And I'm sure there's plenty of weekend warriors out there that have felt that pain. It's usually very more commonly along the inner side of the knee, commonly the medial meniscus, and that in a lot of situations is amenable to a surgical procedure,
Right.
which is one of the most common done, again, very commonly done at the surgery center,
Yep.
which is knee arthroscopy, where basically we take a small camera, which takes a little puncture in the knee. We can put that camera in the knee, and we can do things really with that we couldn't even do if you opened the knee up.
Really?
Because you can get to spots with that camera that you really can't see sometimes
Wow.
with the knee open, unless you're going to really do a whole major procedure.
Right.
In the old days, they would, with a meniscus tear, because they couldn't see anything, they would make a small incision, cut the whole meniscus out because they didn't think it meant anything, and it wasn't that important. And all those people ended up with painless knee then, and then a few years later they ended up with bad arthritis and needing a knee replacement.
Right.
So the scope has been a very key tool in allowing us to not only diagnose problems but also to take care of them. So now we can snip away at a meniscus or repair it back into place, and that knee will be healthy for the rest of that patient's life.
So I want to tell you a little bit about my knee, and then I have a question regarding instability.
Sure.
So back when I was in college, I injured my left knee. I was diagnosed with a torn medial and lateral meniscus. I had the traditional, that was before arthroscopy, where they opened both sides of the knee up, and they did a meniscectomy on my knee. Needless to say, I have severe arthritis in this knee now, and from some of the research I've read, it kind of leads to that if you have a meniscal tear, you usually have an ACL instability as a result of that tear. And if you do a meniscectomy without correcting the ACL instability, you're going to end up with a knee like that.
Well, back then it was probably the case. Now, what you're saying, you can almost say for sure, not definitively, but certainly a high percentage of ACL tears, you'll have a meniscus tear.
Okay.
The other way around, not as much. You can get an isolated meniscus very commonly.
Is that true? Okay.
But certainly, as you said, if someone has torn their ACL and also has a meniscus tear. Now, if you're talking about an older patient who's not going to go back to sports and maybe wear a brace, you can fix the meniscus, clean out the ACL, let them do rehab, and possibly they would do okay with that if they're older. The problem is when you don't have the ACL, as you said, you have a higher chance of re-injuring yourself.
Right.
And also that instability, that shear stress, because remember, the joints are really made to take the axial load or the compression load.
Not that.
When they get the twisting or the shear stress, which is what happens when you tear your ACL, that's not good for the long term. And that's why young people that tear their ACL, it's very common that we go in and reconstruct it.
Right.
The methods that we use now are so good and so minimally invasive. I remember when I did my fellowship, we would admit patients. We'd bring them in, do their ACL, and they'd be admitted overnight because of the, a little bit more of the archaic procedures that we did back then. It was not archaic. At the time, it was cutting edge. But we've come a long way now and developed procedures that we use, again, very small. My incision for an ACL is about that big, just enough to get a graft in. Excuse me. And again, it's an ambulatory procedure. The surgery takes about an hour, and that patient could be up and rehabbing within a week.
Wow.
So even the older generation now, a lot of the weekend warriors that may be 50 or 60 that we didn't reconstruct an ACL years ago, they come in and they want to get it done.
Right.
They want to get back out there. They want to play tennis again.
Of course. So now another question. So I've had two meniscal surgeries, left knee, ACL, right knee, back with the old style that you were just talking about, where an incision from here all the way down to the tibial tuberosity, about that big, and they put two screws in, one on the femur, one on the tibia, and they then put the ligament between. I rehabbed. I probably took 9 months to rehab after that surgery before I could actually start to run again.
Correct.
And then within a year, I tore it.
Again.
Disconnected it. So are they, the grafting material they use, are they still using grafting material and screws drilled into the bone, or is it done a different way?
There are a lot of different ways. I think the most common is what we call an interference screw. So instead of the screws going across and catching that piece on each side, what's now done is once the bone plug is pulled in, the most common way is to take a piece of the medial portion of the patellar tendon. So it has a piece of bone on each side. So one piece of bone goes up into the femur, the other one goes through, the ligament goes through the knee, and the other piece of bone is in the tibia. We now use what's called an interference screw that you can wedge in between the bone and the femur. So there's a hole there. The bone plug is in the hole, but there's a little bit of room. So you can you can wedge a screw in between the two pieces of bone that'll keep it up there very solidly and fix it. The screws will be within the bone, and as a matter of fact, the type of screw I use is one that's made of bone.
Wow.
So it's actually a hydroxyapatite type, or it's made of synthetic bone, but ultimately what will happen is over a period of months, as the graft bone incorporates into the patient's own bone, so it becomes part of it, it's never going to move.
Right.
That screw will dissolve, so there won't be any metal in that.
So you have a ligament attached physically grown into a new bone.
That's correct.
So the screw doesn't even do anything. It's not there anymore, and it's anchored right into their own bone.
That's correct.
Wow, that's wild. That's crazy.
Kind of the way it was before it was torn.
Yeah, yeah. Interesting. One last question, then we got to wrap up the show.
Sure.
Professional athlete, football player, goes down the sideline, makes a cut, his knee pops out, he rips his ACL. He now has surgery done and now wants to return 6 months, a year, and start playing again. How strong is that ACL, and do you think he ever has a chance of being as good as he used to be?
If he has it reconstructed, you say?
Yes.
In this day and age, I'm going to tell you, especially with the incorporation, and we didn't really get into that, but using things like platelet injections, PRP, stem cells, and some of these ligaments are literally dipped in that type of mixture. Those ligaments are probably as solid and sometimes even more solid. So I can tell you that a lot of those athletes, and certainly Derrick Rose, who just came to the Knicks, I hope that's the case, because he had his ACL reconstructed, that they can go back to just as high a level as they were before they tore their ACL.
Our next show, we're going to talk more about stem cell, PRP, all those cutting-edge technologies. But for now, I'd like to thank you very much for being on this show.
It was a pleasure.
It was a pleasure. And our next show will be even more exciting. For those of you watching us on Madhousetv, we'll be right back. For those of you watching us on Cablevision, we'll see you next time. And remember one thing, if what you're looking for is real wealth, join us next time on The Bridge to Health.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi, welcome back to the Bridge to Health. My name is Dr. Tom Dow. And once again, we are here with a very special guest, Dr. Sal Corso. Hi, Dr. Corso.
How are you, Tom?
And again, Dr. Corso is an orthopedic surgeon. Very, very busy practice. On our last show, we talked about many things that he does in practice and for hobbies and fun and things like that, where his training was. But today, Dr. Corso, I would like to get more into some of the cutting-edge things that people are starting to hear about in the media, from friends, new technology. So let's start with, where would you like to start? You tell me.
I'll tell you where I'd like to start. I would say probably, I'm going to say 10 years ago, people started realizing, well, you know, platelets are important parts of the blood that go to an area where obviously if you cut yourself, they go there not only to clot and to prevent and stop the bleeding, but also to send out, they send out certain enzymes, certain growth factors, things that then bring cells to that area in order to allow those cells to heal the area, okay? And they said, well, geez, if we take those platelets and we concentrate them, and then inject those concentrated platelets into an area that needs healing, whether it's, and very commonly in orthopedics, a tendon, a ligament, okay, there's a good possibility that you might be able to heal that without having to do surgery. Initially, the primary use of PRP is what it's called, platelet-rich plasma, okay, was done in the operating room. So I would do an ACL reconstruction. And then I would take that patient's blood, we'd spin it in the centrifuge, we'd take out the platelet-rich blood, and we'd inject it right into that knee, and it would supposedly bring good cells so that it would allow that ACL to heal faster, to incorporate quicker into the patient's own body. The same thing with a rotator cuff. But then they found that, let's say somebody had chronic lateral epicondylitis, or what's in layman's terms is a tennis elbow. What they found was that you would develop a chronic tissue there that was almost like, I would say, in, again, layman's terms, bad tissue. Okay, it was necrotic, it was inflamed chronically. What we do in the conventional way would we, after 2 or 3 injections of cortisone, we would then go in and make a little incision, we'd clean out that tendon, we'd reattach it, we'd drill the bone in order to increase the blood supply. But now they found that you take a platelet injection, so you take some blood from the patient, you spin it in a centrifuge, which we can do right in the office. We do that right in Woodbury. And then we take that platelet-rich plasma and we inject it right into the elbow. We tell that patient to rest that elbow for a couple of weeks, to start getting activity a little bit higher after that for another 2 weeks, maybe do a little physical therapy. And in a significant number of patients, it was found that that chronic lateral epicondylitis went away without requiring any surgery. That ultimately, I believe, led to what is now becoming, I think, a much more popular method, which is using the stem cells. So what did the platelets do? They call the stem cells to the area, or you at least they hope by transmitting those enzymes that they would recruit the right cells to the area. Well, now by taking stem cells, which are what you want to call omnipotent, meaning they can turn into almost anything. You take those stem cells from the patient, and we can, again, do that in the office. We can do it, more commonly, we take it from fat. You can get stem cells either from fat or from bone marrow. The bone marrow a little bit more uncomfortable for the patient, so we will do it from fat. I've done 2 basically trials on patients. I will tell you, there was a woman who is, again, a tennis player. She has 2 bad knees. Certainly, they're not bone on bone, but they're pretty bad. She had been using gel shots, which is something we also use in the office, but again, a little bit more conventional. But that still was not getting her more than about 5 or 6 months of relief. I was able to do a trial on her. I used one sample of stem cells from her belly. I split it into 2. I injected each of her knees. She came back 4 weeks later telling me that her knees haven't felt that good in 2 years, which really was almost a little shocking to me. It's now been about 3 or 4 months still, and I have not heard from her.
Wow.
So I think that's going to be something that will really come into the forefront in the next couple of months even. The problem is right now that the insurance companies don't cover that.
That was going to be my next question.
So they believe that it's experimental.
Right.
But I believe the experimental part is turning into positive results. There is a study that was done in, I believe in Europe, of over 1,000 patients with arthritis of the knees, and they had over 85% good results
Wow.
a year after those
With stem
injections.
cells or PRP?
One stem cell injection.
Wow. I'm coming to you next week. I want to get some stems in my
Something
knees.
to think about.
So let me ask you a question. So you just told the audience the stem cells are kind of like the cells that can turn into anything. It can turn into any type of tissue to help it repair. So if it's injected in your knee, it might turn into cartilage for the knee. If it's injected into a tendon, it might turn into tendon material. So it's kind of like a morphic type substance which will change depending on where it's put, correct?
Correct.
What's the difference between the stem cells that you harvest from your fat and embryonic stem cells? Because I hear all this controversy about harvesting embryonic stem cells. They're supposed to be much better. What's the difference?
Well, again, of course, you have embryonic stem cells are really going to be the initial stem cell in the sense that it's still developing, still growing. So I think in that sense, it probably has that much more of a potential to turn into something, whereas something that's been in your body for a while,
right.
You're almost kind of asking it by putting it into that environment.
So it's like a high-test stem cell.
Correct.
It has more possibility to work.
I believe so.
Interesting.
I think that's the difference.
What other new technologies are you using?
We have really, I think first I'd like to just talk about the practice in general, that we really have everything there.
Right.
As far as technology goes, from the fact that we obviously have top quality doctors that take good care of their patients. We have an MRI unit that does phenomenal MRIs, and we have our own radiologist that does nothing but musculoskeletal MRIs. So he reads all our MRIs for us. We have bracing. We have a physical therapy unit which works very well. We also have pain management. So we have a physician that comes from Stony Brook he's the head of Stony Brook, Dr. Brian Durkin. He's an excellent pain management physician. He's now there once a week, but we're so busy that we're now going to expand to 2 or 3 days a week of having pain management. And we also have a fluoro machine there, so he uses that mostly. We do have the capability of doing some minor procedures in the office. And I think the bottom line is that the one-stop shopping aspect of it is a good thing. I think patients like that. And they can get really their total care.
Right. Well, as I've explained on many of my shows before, that term one-stop shopping is much more than that. It's the team approach to healthcare. Traditionally, if you're in your own office and you're just you there as an orthopedist, you're going to write a prescription for physical therapy. Patient's going to go out, they're going to find a therapist, or you may send them to somebody you know. They're going to treat there 3 days a week. In your facility, like mine in Melville, where we have the whole team there under one roof, that therapist can come out and say, Dr. Corso, can you take a look at this patient's knee? They're in a little more pain today. You walk right across. You look at the patient while the therapist is there. You may say to the therapist, well, let's modify that knee exercise to maybe 90 degrees of flexion instead of 120. Right there immediately as a team, feedback between each of you. Much more valuable than being in separate locations. Would you agree?
Absolutely invaluable. It is just so, not only that, but as I said, I do a lot of arthroscopic procedures. I do a significant number of repairs, and I'll get to the shoulder, which is something I would love to talk about because, as I said, the knee is very common, but the shoulder, I guess I can kind of, I'll intercede now with that and then get right into the therapy part. But,
sounds good.
But I see a tremendous amount of patients with shoulder problems, and I guess once you've treated a lot of them, and hopefully you get a lot of them better, you get more. The shoulder is a very, it's really, when you think about it, it's one of the most wondrous joints that we have because certainly you can move your neck around in different areas, but you know the neck ultimately becomes an issue. But most of the joints move up and down, or they move in one direction or the other, whereas the shoulder really can go anywhere.
Right. And because the reason why it can do that is because there's no articular support. It's just a socket with a ball laying in it, and everything around it has to be supported by muscles and ligaments and tendons. Not like a hip, which is deep in a socket.
You're stealing my.
Sorry.
No, I'm just kidding.
Sorry. Sorry about that.
It's exactly right. It's a ball on a flat socket.
Right.
So as you said, the soft tissue, the labrum, the capsule, and the rotator cuff help to maintain and keep that ball within 2 millimeters of the center of a flat ball, a flat socket rather, which is pretty amazing when you think about it. But that's the reason why there are that many injuries, and of course, when you're talking about overhead athletes and, whether it's baseball pitchers or tennis players or, even volleyball players, I see all of them that have a significant number of shoulder issues, very fixable, and we're able to take care of it. But what I was saying, and a lot of these people will come in, and just to give the audience, so you guys understand, people come in with pain, they have pain at night, they have problems reaching up into cabinets, they have problems lifting things over their head. Those are the kind of complaints we get. They have problems laying on that shoulder at night. They can't sleep on that side. So when they do come in, we go through an examination. We may get an x-ray, ultimately get an MRI. Very common to see a rotator cuff tear. The problem with rotator cuff tears is, number one, if people go in and get an injection, they feel better. Okay, fine, they leave it alone. And sometimes that tear may get worse or may get bigger, may get harder to fix. So if you look at the statistics of rotator cuff repairs, and there are a ton of them that are done across the country, the overall success rate is not as good as you'd like. You'd like to have over 90%. But that's because some of these tears are so bad and so difficult to fix that they ultimately re-tear post-op, which brings us back to the therapy. I want to know that if I fix a rotator cuff, and especially one that might be tough, that patient is going to be taken care of by the right therapist who knows my work and who knows how to take care of the post-op protocol. Right. So that there are certain things that patient can do, and there are certain things that patient cannot do. You also want to make sure that they don't get stiff, so you don't want to baby them too much. But at the same time, you want to make sure that you don't do anything wrong. That's the beauty of having that therapy place right next door and the team approach. So that if there is something wrong, my therapist will come right over and say, Doc, I know what you usually do. Something's going on here. Why don't you take a look?
Awesome. Let's talk about shoulders a little more. So I recently did a show on shoulder injuries with young baseball players. And the interesting statistics, which just came out from a study about a year ago, is that in the 10, 11, 12-year-old age group, that if you limit the kids' pitches per game to 50 or less, they have a 4 times less likely chance of getting a rotator cuff injury than if they go over 75. So, and all the Little League teams, the max pitch count on most of these leagues is 75. They pull the kid. But if they change that with these studies and they bring it down to 50, they have a much less likely chance when they get older to need a surgery. And I truly believe that's why a lot of the professional athletes, the young guys, the rookies, the high school players, they've already had Tommy John surgery. They've already had shoulder surgery at 14, 15, 16, 17 years old. And the new research also shows that it's not the curveballs when they're young that is causing injuries to the elbow or shoulder. It's just over repetitive throwing the ball fast, because as I understand, every time a fastball is thrown, that humerus actually slides out of that socket a little bit, and continually doing that is going to stretch the holding elements of that shoulder. Would you agree?
There's no doubt. I mean, that's why we were talking about the importance of the rotator cuff. Really, the arm almost wants to go with the ball.
Right.
When you look at, first of all, in this day and age, you see how many pitchers throw the ball really over 90 miles an hour.
Almost all.
And almost all, and almost all of them, like you said, either need Tommy John surgery or have had some type of shoulder injury.
Right.
And again, to get back to the PRP, I did have a high school student with an elbow injury. Again, the Tommy John type ligament that they're talking about, or the UCL, which is the ulnar collateral ligament.
Right.
It was partially torn. I had sent another pitcher into the city, and they did surgery on a partially torn UCL. This gentleman did not want to have surgery, so I decided to give him a PRP injection. He came back to me 2 years later, had pitched for 2 years, or almost 2 years, obviously, after he recovered from the injection. And he actually was having some shoulder problems, so he complained a little of the elbow, but it was in a different spot of where he had the initial problem. So I did get a new MRI of the shoulder and the elbow, and sure enough, the Tommy John ligament, the UCL, which was partially torn, which we injected with PRP, was healed.
Nice.
Kind of like Tanaka of the
Nice,
Yankees,
yes.
kind of the
So
same
you had
thing.
a post-diagnostic study which showed what you did worked.
Exactly. So that's a good option to have. But as you said, the pitchers in this day and age and the kids that throw overhand, I agree. And unfortunately, I saw it even with my own son, who pitched varsity baseball at high school. If he was doing well, it honestly didn't really matter. And there were even times when the coach was calling, 3-1 curveballs. I mean, these are high school kids. As far as I'm concerned, let the kid hit the ball, throw it over, don't put the extra strain. But the overhead throw, a lot of these kids I will see with a little bit of instability, as you said, because that constant pulling does stretch the capsule. And but a lot of times you can get that better with some therapy and, as you said, limiting the pitch count.
The most difficult challenge for both the coaches, the player himself, and the parents is when you're 11 years old and you got a tie ball game in the bottom of the sixth and your kid's pitching a no-hitter. Once he hits that pitch count, for the parent to say, he's got to come out. You're going to get booed by the other parents. You're going to get, your own kid probably will want to hate you for the rest of your life. But what they don't realize is it's just one game when they're 11 years old.
That's correct.
That might affect their future.
That is correct.
And it's a hard situation.
Well, you know what? I'll give you a perfect example, and I can talk a little bit about myself as well, going through residency. When I did my residency at LIJ, again, this is over 25 years ago, there were a lot more patients in the hospital, people that were not discharged the next day or whatever. So we had a round on a lot of patients. And at the time, I was young. I was 30 years old. I had to see 40 patients on a morning. I would go around, I'd have to change dressings. I'm a tall guy. Instead of lifting the bed up to me, I would be in a rush and bend over and do what I had to do. 30 years old, I didn't have any back pain, didn't bother me at all, no problem. Nurse would say to me, Doc, you got to watch your back. You're going to have a problem. I'm now 56 years old. At 40, I had a gigantic herniated disc. There's no way that happened at 40. It probably started back then. So I think people have to understand, and these people that, again, the weekend warrior, these guys doing these cross trainers and all these crazy exercises. They look good from the outside, but they're wearing down their inside. So they, you got to take care of your body. You really do. You have exercise is great, but a little more low impact. Don't run 20 miles on concrete. It's not a great idea.
Repetitive stress injury is like the most devastating injury because you don't even know it's happening when it's happening. The office workers that sit at a computer all day with the improper ergonomics, so their wrists are up like this instead of where they should be. Their heads are turned like this in their monitors. Over a lifetime, I mean, if you look at my wrist, I mean, severe arthritis, that's from 32 years of pounding on people, adjusting them with my hands.
Correct.
It felt great while I was doing it.
Of course. And you were getting paid for it, which was good.
I was getting paid for it.
And you were helping them.
And I was getting people well. But it does take its toll.
Sure.
And, unfortunately, when you're young, you think you're invincible.
And the problem with the repetitive stress, as you said, is it causes a degenerative type problem. It's just something that, unfortunately, unless the stem cells can help us,
Right.
is really not reversible. It's the acute injury sometimes. If somebody tears their cuff,
Right.
acutely, you could fix that.
Right.
But it's the guy that, as I said, hurt his shoulder, has a little tear, you give him a shot, he feels better.
Yep.
He goes back, he does his thing, he comes back, maybe, oh, doc, one more shot. And then 2 years later, you've got a huge hole, degenerative tissue that's harder to fix, and those are the ones sometimes that'll fail.
Let's talk a little bit about joint replacement therapy.
Sure.
Knees that are shot, knees that are bone on bone, replacing that joint. What's involved in that, and how long is the recovery period? Who are the correct candidates for that procedure? What age groups? Can we talk a little bit about that?
Sure. I did some joint replacements even as an attending, but certainly I did some in my fellowship and with the doctors that were instructing. It's a great operation. Obviously, the knee is, I think, the more common, the two most common joints that are replaced are the hip and the knee. And I can tell you that certainly the knee is wrought with a much more high complication rate, but certainly not a high, and just more higher than the hip, not high in general. Most people do very well. The problem is when you do have a problem, but we won't start with that. It's, again, the patients, usually with a hip, the life of a hip replacement is probably 50 years, I'm going to tell you. So
now, when you say hip, do you mean the socket and the ball?
The socket and the
Both?
ball. So what happens is, just like in the knee, the two bones that are connected have cartilage on each end, and that cartilage wears down to a point where it's almost bone on bone. In the knee, the problem is that the knees only last a certain amount of time because there's a different types of stress, as you would know, on the knee than there is on the hip. So those will wear down. So you really try to push off a knee replacement.
How long?
At least until your 50s, at the minimal. And you're probably better into your 60s if you can.
How long does it last for?
As I said, it's probably 20 years. And if it's real good, maybe 25, and they're getting better at it. But a hip, as I said, can last 50 years. So you can have a hip replacement when you're 35 and you probably never need another one.
Right.
The problem is if you need to revise one, as you did in the knee, if you do a 45-year-old person and do a knee replacement and they need to have that revised at 65, the cement, the metal, all causes the bone to have a little bit of reaction, and ultimately the bone kind of becomes osteoporotic or osteopenic. So the next time, now you have to remove the prosthesis that's cemented in and then put a new one in.
Yeah, into an osteoporotic bone.
Correct. So it does cause some issues, and it makes it a very difficult thing. I tell all my patients, and I don't do the replacements anymore, but I tell them, you want to do a replacement, you don't want the doctor to tell you. You're going to do it when you're ready and when it affects the quality of your life. Doesn't mean that you should be, having pain every day. I mean, it affects the quality of your life. That's when it's time to get your knee replaced or your hip replaced. Mm-hmm. But you have a little bit more leeway with the hip. Right. You can do it a little earlier.
Well, tell me about the procedure. How long is the actual operation? Describe to the audience what they actually do in the procedure.
Sure.
And then how long the recovery and rehab is after it. And
first, understand that there are thousands of these done every day in the country. It seems like a very gory surgery. It really isn't. It's done very systematically. The knee is open. There is an incision that's made over the knee. Sometimes they're a little bit less, depending on the type of surgeon that's going in there and doing their procedure. But you have to expose the ends of the bone. So all the ligaments and everything can come off, but all the muscles and everything around the knee stay in place. There is a tourniquet on the leg, so there really is not a lot of bleeding. Most of these procedures can be done within an hour, maybe an hour and a half at the max.
Wow, I thought it would be hours.
You would think, but as I said, there are literally steps that are done. There's usually a rep in the room, not in the case. He's off to the side. He's telling the nurses what is to get ready to get next, give the surgeon next, so that the surgeon can just literally reach over, get the next piece of equipment, and do what he has to do. As far as cutting bone, you're not cutting out an entire joint. You're just cutting the ends of the bone so that you can make it the right form to fit the prosthesis in place. The prosthesis has to fit very snugly. It is cemented into place. We use a very fine bone cement. There is only a minimal amount that's put in between the metal and the bone if you were doing a knee. Everything, again, is measured exactly. All the cuts are measured. As a matter of fact, they're now instituting in some places a robotic way of doing this, so a robot will actually do the surgery even though you're telling it what to do.
R2-D2.
Exactly. Technology at its best. But this is a very controlled environment. There's not bleeding going on all over the place. Before the tourniquet is let loose, all the bleeding is controlled. Everything's washed out and closed. The knee goes back just the way it opened, with much more healthy stuff in there than.
Do they have to reattach all the ligaments to the new prosthesis?
Most of the ligaments can be left. The ligaments in the middle of the knee are replaced really by the prosthesis and the way it's developed. Some are more constrained than others. They fit into each other better. So the ligaments that are essential are the ones on the outside. They're really not touched during the procedure.
Right. Dr. Corso, this has been a very, very informative and interesting interview. I want to thank you again. And just once again, just look into the camera, tell the audience how they can get in touch with you if they need to, if they have any further questions.
Thanks, Dr. Dow. Again, my name is Sal Corso, C-O-R-S-O. My office is Orthopedic and Sports Associates of Long Island. We're at 205 Frolic Farm Boulevard in Woodbury, Long Island, literally right off both of the main parkways, right off Sunnyside Boulevard. And my office number is 516-364-0070.
Thanks again, Dr. Corso, and I'm sure we'll have you back again.
Thanks, Doc.
Thank you once again, audience, for watching The Bridge to Health. We look forward to seeing you next time. Remember one thing, if what you're looking for is real wealth, join us next time on The Bridge to Health.